Hey, everybody, and welcome to the 6th Annual Parent Network Workshop. We are pleased to have you join us for creating a recipe for success, mixing and matching mental health services, mental health and developmental disability services in your treatment plan. Before we get started, there's just a few housekeeping items. If you have any questions during the session, put them in the Q&A and that way we can make sure that we catch them. You can also use the chat to discuss amongst yourselves. In the coming days, we will be posting this recording along with the slides and any resources that we discuss on our website at idahoparentnetwork.org. Feel free to share those with anyone you think that could benefit. And with that out of the way, let's go ahead and introduce our presenters. Today we have Sarah Allen joining us from the Department of Health and Welfare. We have Dr. Abalash, Medical Director, Developmental Disabilities Crisis Response Team. We have Amy Liu, a parent from the Parent Network. We have Bedrin, see, I told you I was going to mess up your name, Bevan Modrak joining us from Optum, and Nate Perlman and Danielle Weimer both joining us from the Children's Therapy Place. So during this session, we want you to learn that you're going to understand the complex nature of treatment planning for dual diagnosed kiddos. You're going to know the difference between youth empowerment services, known as YES, and the Developmental Disability Program. And you're going to be able to identify ways to create a collaborative care plan. So with that, I'll go ahead and turn the session over to Amy Liu, and I hope you enjoy.
Thank you. So I am Amy Lofney, or Amy Liu, sorry, otherwise known as Amy Liu. And I am the mom of 7 kids, all with mental health diagnoses, but 4 of them are dually diagnosed. And so I understand how it is to be overwhelmed by working and navigating through both systems of care. And it can be very confusing, especially when you have dually diagnosed children. So I am here to kind of give the parent voice and just kind of give the parent point of view of how that works and how I've kind of made it work for my kids. Next slide. Sorry. So developmental diagnoses often come with mental health diagnoses. And mental health diagnoses can look very different in children with developmental diagnoses. So for instance, an autistic child who has a mental health diagnosis is going to function very differently than another typical child with a mental health diagnosis. Children with dual diagnoses have very unique needs and can often create challenges in maneuvering the systems of care. And we have found that with my own children. We've had to figure out which therapies actually work and which system we need to use for particular therapies. Often one treatment goal can be approached by both systems, and frequently a service from one system can touch multiple issues. And we have also found that to be true. We have worked with occupational therapy, for instance, to accomplish both mental health and developmental disability goals, which has really helped out a lot. So to help us understand developmental disability services, we have Sarah, and I am going to turn the time over to her.
All right, thanks, Amy. So developmental disability services for children in the state of Idaho, I kind of like to think of it as broken into intervention services and support services. So intervention services are available to children that have that behavioral need. They come out of the state plan. So what that means is you access those services like you would occupational therapy, speech therapy. You would go directly to the clinic with your Medicaid card to seek out those services based on your child's need. And they can be provided in the home, community, or the Developmental Disability Agency, and they address those behaviors, the intervention does. And then we have support services. Those are services that facilitate an individual's independence or their integration into the community, supporting the child in their natural environment. Also, respite falls under this. It's provided in the home or community, and there's 2 pathways for this service: traditional support services and family-directed support services. And I'll go into how you are eligible for those. So for intervention services, you need to be Medicaid eligible for all services, starts with Medicaid eligibility. For intervention, it's birth through their 21st birthday. You must have a functional need or combination of the functional and behavioral needs to show that you have the need for intervention. A recommendation by a physician or practitioner of the healing arts saying that this service is medically necessary. The needs determined through a screener using screening using the Vineland. And you have to show that you have a deficit in those following areas, those 7 life skill areas. So children's intervention services are behavioral intervention, skill building, interdisciplinary training, and crisis intervention. So those 2 first services are really addressing those maladaptive behaviors and working on building coping skills and new behaviors to help address those behaviors that the child's exhibiting. Interdisciplinary training is for the interventionist to work with other professionals in the child's life. So the interventionist could meet with the speech therapist and they could both bill and consult at the same time to work on consistency with the child's professional services. And crisis intervention is additional services of the intervention services that we can put in place if the child is experiencing a crisis. And those are 30-day authorizations that we can give. So eligibility for support services. So that's kind of our second bucket of services that child may be eligible for. The child must have Medicaid. It's birth through the 18th month. So these services go up to when the child turns 18. Case management comes along with the traditional budget. So this is the budget of money that families get awarded from Liberty Healthcare. They go through eligibility for those support services there. And then after that, they get a case manager that can help them set up their traditional support services, or then they can learn more about family direct services. So the families on Family Direct, the family's in charge of managing that budget and how they see fit for addressing their child's needs that are medically necessary. So in order to qualify for a support budget, the child must have a developmental disability diagnosis. So autism, intellectual disability, cerebral palsy, seizure disorder, or closely related condition. And so that's different than intervention. Intervention is just the need. The child does not need to have that developmental disability diagnosis in order to qualify for intervention. So community supports, support services include the community-based supports, respite, and family education. Those will come out of the kind of that traditional bucket. And then the family-directed budget, again, the family is in charge of hiring those support staff that they want to work with their child. Okay, breeze through that.
Yeah, I was gonna say we're ahead of schedule. That's good. So now we're going to listen to or turn it over to Bevan to help us understand the Youth Empowerment Services System of Care, which is for mental health diagnoses.
Hey, thank you very much. I just, since we have a little bit of time, I'd like to cover a little bit about the origin of the YES system of care. It came out of a lawsuit surrounding a Idaho Medicaid youth who was placed in a adult facility because there was a lack of community-based behavioral health treatment services. And that lawsuit is, I think, something like 38 or 39 years old now. So it actually predates me with the department. But as an outcome of that, as part of the class action lawsuit, in negotiation with the Idaho State Supreme Court, what came about was the Youth Empowerment Services, which is really a way to try to beef up the community-based behavioral health services for kids in our community. So with that backdrop, let me talk a little bit about the differentiation between youth empowerment services and who's eligible for that versus behavioral health services that youth are eligible for under straight Medicaid. So most of our Medicaid members have access to the full array of Medicaid funded behavioral health services. So youth who are eligible for Medicaid and those who may not be eligible for Medicaid can still access those by being qualified for YES services. So there's a different eligibility criteria between those two services. For both those services, when they're eligible, it's birth through their 18th birthday. And it requires a combination of mental health diagnosis and a functional impairment as identified by the CANS assessment, which stands for Child Adolescent Needs and Strengths tool. So that is a functional assessment, identifies some deficits that the child or youth might have in certain functional areas. If this sounds very analogous to what Sarah was talking about, there's a lot of parallels, which is exactly why in many respects, parents can get very confused because the acronyms don't stick. As a parent, as Amy Lou and some of the other parents can attest, when you're first engaging in the system, bunch of acronyms, they don't always stick. And you're told to go do this, go do this, go do this. So hopefully this will help serve as why you might have a Vineland and why you might have a CANS for a child that qualifies for both services. To qualify for YES, there's a different income eligibility criteria for YES services. Also, Liberty Health is the state's vendor for doing the assessments for YES criteria, which utilizes both the CANS assessment and also a comprehensive diagnostic assessment to establish that there's a behavioral health diagnosis. So really at this point, the difference between the two, you might get a CANS for straight Medicaid eligibility, and the financial criteria is quite a bit more stringent for straight Medicaid. For YES eligibility, it's both the CANS and the assessment by Liberty. Next slide, thank you. So the services provided, and again, I'm going to break this down in terms of the majority of these services are available for any youth or child that has Medicaid and has a behavioral health diagnosis. And then I'll finish up by talking about what's specific at this point in time to YES services. So all services for behavioral health starts with an assessment. That's both a comprehensive diagnostic assessment and a CANS assessment. Once the determination for the services is made and the youth qualifies by having a behavioral health diagnosis and having demonstrated needs, the services available include case management, which is about linking to other services and communicating between professionals, psychological and neuropsychological testing, targeted care coordination, which is very similar to wraparound, which right now under the Idaho plan, wraparound specific to the Department of Health and Welfare, but under Medicaid, we also have targeted care coordination, which is a more intensive service than case management. Again, all services require treatment plans, so treatment planning is included. There are crisis intervention services, family supportive services, because as anyone who has a child with these challenges can tell you, it's very challenging for the family and they often need help navigating the system. There's respite services, and I'll talk more about that towards the end. There's youth support systems, which is a youth that has navigated the system and can work with another youth to help support them in their journey. Behavior modification, which is very similar. Actually, it's the same criteria of training that is true for the behavior modification under the developmental program. Day treatment services, intensive home and community-based services, which is an in-home family therapy program. We have intensive outpatient programs, which includes a partial hospitalization program, medication management, psychiatric residential treatment, which I'll talk more about in a moment, both individual and family psychotherapy, and skills building and community-based rehabilitation services. So that's the full menu of services that's available under the Medicaid plan. What is specific to youth empowerment services, or YES services at this time, is respite. And again, to qualify for that, you would have to go through an assessment by Liberty to qualify for YES services and the CANS assessment. The rest of the services are available by, again, much like Sarah talked about, finding a provider that of your choosing, taking your child there to have an assessment, and then the services would be put in place based on what the assessed needs are. Psychiatric residential treatment is unique in that it can only be funded through Medicaid dollars by accessing through the EPSDT process, which is specific to the Medicaid Department of Medicaid, and that's a separate application process, different than if you go to your local behavioral health provider. EPSDT is another one of those wonderful acronyms that stands for Early Periodic Screening Treatment, or Developmental and Treatment Program, and that's a separate assessment program altogether. So again, to recap, most of these services are available if you qualify for Medicaid. If you wish to access respite, have a need to access respite, your child would have to qualify for the youth empowerment services. And psychiatric residential treatment is assessed through the EPSDT process. And yes, I always get the acronym mixed up. So if you see down below, that's the correct way to that the acronym stands for. Again, after almost 30 years, you'd think I'd have this straight, but I always get this a little mixed up. So with that being said, I think I'm finished, and we'll turn that over to Amy.
Thank you, Bevan. So those of us with dually diagnosed children, we know that in a perfect world, everything on the mental health side and the developmental disability side would work together. That would make lives a lot easier for families. So to introduce that idea and to kind of talk to us about collaborative care, we have Dr. Abalash. I hope I said your name right. And he's going to talk to us about bringing both worlds together to create effective treatment plans.
Thank you, Amy. Delighted and honored to be here. So I have been treating children and adults with both intellectual disability and a psychiatric diagnosis, say bipolar disorder, or autism and bipolar disorder. I'm just giving that as an example. And it's very important for us to, as Amy mentioned, balance both the goals, because even though they are different, both of them are important. And if one area is not adequately addressed, say the mental health, if there's say bipolar disorder is not adequately stabilized, then it'll be very hard for the child to benefit from any other services. And for this, obviously, we need to collaborate, work together as a team, because as one of the goals of this presentations is that the needs are very complex. And whenever you have complexity, you have a team, preferably who knows what they are doing, and try and slow down the process as much as is possible. And also to over time develop trust. So both when I see my patients and their family, when I hear that they are not only loving and caring, but also have done some homework, and they come with me and tell me that, we are aware that there could be medical illnesses that could cause my child to have problems. These are the medical illnesses that he has had before, just for you to know. We are aware that certain medicines can cause problems, but we don't know a lot, so please guide us. We know that there are social factors that can cause or add to the behaviors, maladaptive behaviors, like some children do better with one team member rather than the other. So obviously the approach differs. That's a social factor. We are aware of the environment. There is too much noise or other environmental factors that could be adding to the problem. We are also aware that lifestyle is important. And all these would translate into treatment, so that when I recommend, I just don't recommend medications. I recommend many other interventions because we want to have a holistic approach. And for all this to happen, especially nowadays, but even honestly, in the future, even without the pandemic, I think telemedicine, telepsychiatry is very important. In some cases, I think it'll be even more valuable for the parents, because the stress of taking the child for the appointment, spending time, waiting, all that will be eliminated. Sometimes it's easier for me to see the child in the place that they're living. Telepsychiatry allows me to have a whole team via Zoom or WebEx, where we have psychologists, social workers, board certified behavior analysts, the parent, the targeted service coordinator, and any other team members, so that we can come up with what areas we should focus on, what are the goals, and what's the best way to go about. And for me as a provider, having electronic medical records is absolutely important, because then I can do a lot of work ahead of time so that I'm better prepared to answer the questions that parents or the child may have. Again, how do you determine highest priorities? Again, we collaborate, we talk to each other. My goal might be that we avoid hospitalization, we avoid visits to the emergency department, we avoid any as needed psychiatric medicines. But that is very different than many other priorities that the child or the family has. And again, communication. So many times I find that parents or the care providers have much more expectation from the medicines than I can deliver, or I believe that any psychiatric medication prescriber can deliver. And the opposite is true too. If you don't adequately control serious psychiatric symptoms, such as psychotic symptoms or manic symptoms, then the whole life is going to just stop right there. So we need to, but then I worry that sometimes the team members of the family feel that we should use less medicines. And again, in some cases, that may not be a good thing from my perspective. I can answer, many other questions. I may not have covered a lot of things. Thank you.
Thank you, Dr. Abalash. I like how you talked about the expectations of the providers and the families and the child. And sometimes it really helps to have, everybody on the team on the same page. I mean, not sometimes, all the time. It always helps to have everyone on the team to be on the same page. And so that communication is very vital, and keeping records is vital. So two people who know what it's like to work together on both the developmental disability side and the mental health side are Nate and Danielle, and they are going to help us understand collaborative developmental disability care.
Hello. So I think that one of the really important things that we as families and providers need to remember when we are talking about dually diagnosed kiddos is that oftentimes the treatment needed or available is so vast that can be really overwhelming at times for families. And so if you've got a kiddo who, for example, has autism along with maybe ADHD or generalized anxiety, and, they're being told by a primary physician that they need behavioral intervention and physical therapy, occupational therapy, speech therapy, mental health therapy, that's a lot for families to process. And I think it's super important for us when we're collaborating as a team to make sure that we're really talking with families about what they feel like priority care is for their kiddos. And so that can include whether we start with things like behavior intervention or physical therapy or occupational therapy. But I think that everyone sort of getting together and having that conversation and helping families break down for themselves what each individual service is and how that can be most beneficial for their kiddo, and then really starting from there. So when we're developing those collaborative plans, like I think everyone has said, we're all getting on the same page in terms of care for the child, but also making sure that we understand where the family priorities and where the kiddos' priorities are so that we can help move them in that direction.
I think it's important to keep in perspective that word, that letter E in yes is empowerment. So I think a big thing is to make sure parents recognize that they're empowered, that there's all these services and there's so much on their plate, helping them understand which one do you feel like as a parent or as a child or as a client is going to be the best starting point, and that not all of those have to be done all at one point in time. And I think helping parents understand that we want them to be at the forefront and leading what they think. They know their child better than we know their child. They've been with them since birth. So just helping to guide that. We're fortunate being here at Children's Therapy Place that we have a lot of these services under one roof. So we've tried really hard as a team to be collaborative amongst ourselves with the disciplines, but also trying to really engage the parents and the clients in understanding that, we want them to help us to set those goals and the priorities of those goals.
Yeah, and I think that when we're talking about creating realistic plans, that it is really important to take into consideration all of the factors that are going on in a family's life and all of the things that they're having to navigate right now, because I know that a lot of times we have families who come in and they're signing up for developmental services and they already have mental health and speech and OT and PT and aquatherapy, and they just are feeling like they're living in the office, and they feel like this is something that they have to do because they really want to advocate and make sure that their child is getting everything that they need. But I think it's so important to really, when we're coordinating those realistic plans, to come together as a team with a family to say, okay, so what are some things that can cover, what is a service that can cover multiple areas that you're wanting to address right now? And how do we coordinate and make that happen? And what does that priority look like? And I think really working with a family to determine, are they overwhelmed right now? Are kiddos overwhelmed? Is throwing all of the things at one particular issue really that effective? Or is there something that we can, is there one service right now that's really going to hit those points that are going to be super important for the family and child?
And trying to recognize, sorry, I have one more quick point. Just trying to recognize when we're sitting down in the mental health side, like Bevan was talking about, we do a comprehensive diagnostic assessment. We do a CANS. We do a treatment plan with families. And in that process, we try to set priority on the goal and basically help a family understand if we can alleviate some of the issues with this goal, do the other things fall in line, and do some of the other behaviors or other problematic symptoms kind of alleviate themselves. So they oftentimes come in just with all of these ideas and all these stressors, and helping them to really compartmentalize that and say, if we work on the idea of reducing anxiety or reducing fear or reducing that, then a lot of the other behaviors kind of go by the wayside. I think also working with the community and the other agencies that we have available, reaching out to their medication managers, reaching out to other disciplines that are outside of our agency, I think is imperative. It is, and really helping parents to realize that they're the advocate for their children and that they have a voice, and that there's no stupid question, there's no stupid idea. They are our eyes and our ears, and they're oftentimes 99% of the time the people in the trenches. So helping them realize that they are part of the team, they're not outside of the team.
Thank you very much. That was a lot of good information. Just for our participants, if you have a question, please put it down in the chat so that we can see it. That would be very helpful for us as panelists so that we can get to your questions adequately. I always have this joke of you can over therapy your child. And the reason I say that is because when my first child was diagnosed with developmental and mental health, I was thrown just tons of information. The neuropsychologist gave me just pamphlets and stacks of information and therapies, and the report was so detailed about everything my son would need in order to function. And at first I thought I needed all the therapies. We have to do all the therapies. But then even I was over therapied, and my eyes were really opened when my son decided to self-advocate. And he said, "Mom, I feel like I don't have time to just be a kid." So the therapies weren't really working for him because he felt like he was almost being attacked by too many appointments. He couldn't even think through what he was trying to learn because it was way too much all at once. So we need to remember that we are one person, we are only one family. And if you're like me, I have multiple children who are dually diagnosed. And so, Danielle talked about how people feel like they live in the office. We have narrowed things down, and I still feel like I just live in our kids' therapy office. So there really is too much of a good thing. When you realize that when you have so many therapies going on and your child's not fully benefiting from all of those therapies, all of that time and energy that goes into it, we really have to step back and think about it. And I have really learned a lot lately with teaching my children to self-advocate. I can be an advocate too. But if my child feels like something's not working, I need to step back and I need to listen to that input and make sure that what I'm doing really is what is best for my child. And a lot of times they can tell you, hey, this is really too much for me. My son was able to tell me which therapies we needed to drop. I'm thankful I listened to him because things are going so much better now. And we discussed it with all of the people on our team, and they agreed. So sometimes if you're not sure what that priority is or what is the most emergent need, talk to your kids and see if they are able to let you know. And also behavior is one of those things that is communication as well. So choosing the services that have multiple function is a good way to do it. I bring up OT because that's been the biggest blessing in our family's lives. because our occupational therapist doesn't just work on coordination and doesn't just work on, those life skills. She works with them on sensory processing. She works with them on self-regulating, which has totally changed our lives on the mental health side of things. And she works with their counselors and their speech therapists. So we figured out that my son needs to be able to communicate his needs. That helps us a lot with how quickly he escalates. So speech therapy is absolutely necessary. We also figured out counseling. We need to have that. He needs to learn how to adapt and to self-regulate. And OT only adds to that. So we have narrowed it down to only 3 therapies that he needs to be in at one time. And sometimes he takes breaks from certain therapies. When he's on a break from one therapy, he'll do feeding therapy because he has an aversion to foods and textures, and we absolutely need that. So it's okay to take breaks. It's okay to step back and not necessarily have to do everything at the same time. So some things for parents that they might want to consider is, listening to your child. Is it working? And making sure that, like Nate said, we do have a voice at the table. We are part of the team. I like that Dr. Abalash brought up that, do you really need the medication? Or maybe you need the medication so that the other therapies will work for your child. We learned that the hard way with my youngest. We found out and realized that her anxiety was it was like way up here at the top of the mountain. And so it didn't take much to push her over the edge. And just the idea of going to counseling was overwhelming and would send her into full-on emotional meltdown. And so we realized that she needed the medication to take off the edge so that her counseling sessions would actually work for her. So those are some things that you really might want to consider. And one of the things that Dr. Abalash brought up that, especially when it comes to medications and things, keep the reports that your professionals and your providers give you. Keep those on hand, keep the evaluations, keep the medications, the list of medications that don't work and why they don't work. I know that in discussing things yesterday with Dr. Abalash and Laura, that's a very helpful piece of information for the providers, is if they know why a medication doesn't work, they're not going to send you down that road again. And keep that communication going. And try to keep as many services in the same place as possible. That's something that has saved me. All of our services are at the same place in the same building. And so I can actually have 2 kids in 2 different services at the same time, which gives us more valuable family time and allows them time to just be a kid and not have to be in therapy all the time or not have mom gone all the time. So, and utilizing those case managers and the targeted care coordinators and getting everybody on the same page, that is a good opportunity for you all to discuss what's the most needed. So I would like to hear if there's anything that any of the panelists would like to add to that or even elaborate on. If we're going to open it up for discussion on that.
Amy, I'd like to talk about kids that are duly enrolled in the DD program as well as the YES program. The DD case manager can act as that child's targeted care coordinator to help navigate not only our DD services, but also mental health services that are out there. Wanted to clarify that, and that takes one additional meeting off of someone's hands, having then to seek out a targeted care coordinator. So
that's very good information. Nate, did you have something?
Yeah, I would add just on top of the keep all reports that most agencies, most services, everybody usually has their treatment plan with the goals. But if you think about multiple services, that's multiple treatment plans and goals. So wherever possible, having those at your disposal to be able to share with other disciplines. We're fortunate in that we're able to collaborate with one another and have those goals and have a better understanding of what their occupational therapy goals or what their physical therapy goals or even what their CDRS goals and their mental health goals are. But for parents, making sure that you kind of have a good understanding of those. And if you don't, please ask questions. We try to do treatment plan reviews. There's oftentimes we struggle to get parents to participate in those treatment plan reviews, but they're important. They occur a minimum of every 90 days. And it's a good opportunity to talk about what's working, what's not working, when we need to shift in frequency, when we need to shift in is this goal working? Do we need to scrap it? The other thing that you said, Amy, that I appreciated is when we're collaborating with other disciplines, oftentimes we'll be the second, third, fourth discipline brought in, and they've already started a relationship with, say, the occupational therapist who might be doing some self-regulation, and they might already be teaching them some skills. It doesn't make sense to us to start them learning a whole nother set of skills if we can adapt and adopt the skills that they're already working on. So just making parents aware that that's how they can advocate too.
Yeah, making sure they have that reinforcement,
Right.
having my son work on the same goals with all of his providers has been very vital in his success. So we had a question about about feeding therapy and where to get that. I get it through an occupational therapist who is actually specialized in feeding therapy. So it's actually part of the occupational therapy umbrella. And you can check with your child's, wherever you go to for your child's therapy place. If they don't know of someone, we just went back to our pediatrician, and he referred us to someone. I came right out and told him I don't want to go to 50 different places for my kids because the travel time, it's just so time consuming, and I just don't have it in me to be doing that all day, every day, 5 days a week. They need to get their education. They need to be able to play. So we were able to find one at the same place that we go to. But there are feeding therapists throughout the Valley. So if you don't know who to go to, talk to your providers. We have an occupational therapist that works specifically with, all the other things occupational therapy does, like sensory integration and self-regulation and all of that. And even she was able to give us referrals for feeding therapy. So just make sure you're opening that communication for your providers so that they can help you find all of the things that you need to be able to find. Bevan, did you have something to add?
Couple things. Don't forget that your school, through the IEP process or the 504 process, will also have evaluations and a treatment plan of sorts, and that you're going to want to have all those things available also for your other providers. So when you're looking at the overall list of services your child might need, those are something that tends to be overlooked a little bit or compartmentalized maybe. I can't agree more with this whole idea of being over-programmed, both as the child and the parent. I have an adult child with a disability. I've walked this path. I understand fully about how you want all the services you can possibly get to the point where you exhaust yourself and you can exhaust the child. And then pretty soon you're treating some of the behaviors that may be due to just being overprogrammed, tired, right? Mm-hmm. You start treating those as something that's a pathology as well. And so keep in mind that if you have a 10-year-old child who's getting services through the school, then maybe after school services, and then maybe some other behavioral health services that may even be on the weekend. I just love what you're talking about, Amy, that I'm not on my best behavior if I'm exhausted. Why would you expect a child with challenges to be on their best behavior with all the service providers all the time? And transitions can be a very, very tough thing. So this idea of having as many services under one roof just makes perfect sense to me. If you're running all over the place, every transition is a point of stress and anxiety for a lot of kids. And that's also when behaviors can act out. So I just really love what you're talking about, when everyone's contributing to the conversation. But I would also say it's really up to you as a parent to keep that timeline of services, including medical and behavioral health services. The older your child gets, the more children you have, you really do. I would encourage everybody to have that written down. I can't remember every single procedure my child's had. She's 32 now. And as they get older and you have more children, if they have special needs as well, a lot of those things start getting fuzzy and start getting blurry. So I'd encourage everybody, your record system is your friend.
Yeah, we actually have a binder on every child that needs services. And that's also helped because we've had sometimes where we've changed providers and they don't always have all of the information. So when you do want all of your providers to be on the same page, it's really important to make sure you sign that release of information and get that in there so that they can collaborate, so that they can share information and help you all get on the same page. They legally cannot without that. So make sure you have that in there. And then it looks like we have another question. What if I don't like someone or a specific service on the treatment team or plan? So that is when, and I'm going to open it up for discussion to the panel as well, but as a parent, that is when I use my voice and I help my child use their voice to let the team know that this just isn't working. And honestly, most of the time it's not because there's a team member that's a bad team member. Sometimes it's just not someone your child really works well with, or maybe you don't work well with, or maybe you have different communication styles. We've had to change occupational therapists and counselors for that very reason. And no one was offended. It wasn't like it was you're fired type thing. It was more of a, you know what, my child really would work better with someone who communicated more like him, or, you know, who had a calmer tone or seemed more relaxed, because my son really gets worked up whenever he's around people who are really excitable. And so we had an occupational therapist who was just naturally super enthusiastic. And I thought she was great. My son, however, would get super stressed out every single time we go. So occupational therapy was not working. So now we have one that is super calm and her voice is very calm and he is doing amazing. So just make sure your voice is heard and you're part of the team. Just like Nate said, you are part of the team and your voice is just as important as everybody else's. Does anybody else have anything else to add to that?
Well,
Okay.
Amy,
Oh.
I would just
Go
go
ahead.
along with what you're saying. Like, so I supervise the case managers over the developmental disabilities program. So just in our West Hub, we have 20 case managers. So, I mean, you don't want to reach out to someone's supervisor, but maybe it takes going there and maybe, you know, if someone's not showing up for you the way you want them to, or it's not a good fit. I think, you know, I always tell families, like, we have 20 other case managers to pick from. Let's find you the right fit. This person should be making your life easier, not harder. So if you feel that, reach out to other people to figure out what changes need to happen.
And the follow-up question to that was, what if I don't feel heard by the treatment team? And I would say that what you just said, Sarah, maybe you do need to go, you know, to a supervisor or to somebody who has a little more authority over your team members. I haven't run into that yet. Does anybody else have any suggestions on what a parent can do in that situation?
It depends on the specific example, you know. If, like, to me, if their voice is not being heard because they feel, say, hypothetically, that I'm giving too much medicines, and I feel that they need those medicines for stabilization of bipolar, because you can't manage bipolar with, say, nutritional therapy, counseling, and supplements. So to me, that's a very different example of not being heard. So I think it depends on what the specific context is.
That's a good point.
Well, I think it's so important too for you know, however whether it's the agency or through the department, however there is a process for the family to advocate for themselves, because I think so much as a supervisor of people providing these services, that there are a couple of things that happen when families don't speak up. One is that sometimes the kiddo doesn't get the sort of care that they need, and the family doesn't get the care they need. And so there's almost a delaying in progress because we're trying to just make it work. And two, I think that it also, when families speak up, it really provides some training opportunities and some opportunities for providers to grow and to hear from families what's really important to them. And I think that that growing potential is super important as well. So I think that anytime that you can just, speak your voice, because I know that there have been times where families have called me and they've said, I felt like this for months and months, and I'm like, please, next time, please just let us know so that we can help fix whatever the issue is, whether that is a change in providers or whether that's a team meeting or a conversation. However we need to address that, it's really important for us to be able to do that in a way that maintains that family's dignity and the child's worth, and just really makes them feel like they are part of that process.
That's very good. We actually ran into a situation with one of my children whose counselor had all kinds of trainings and things that they were doing that would happen to fall on the day where she had her counseling sessions. And so her counseling was very spotty. She needed weekly counseling, and she was lucky if she got once a month counseling. And even then, sometimes that wouldn't happen. We weren't always notified of when when things were being canceled on our end, and it was telehealth. So on our end, it looked like we still had an appointment, and we would log in and there would be no one there. So what we ended up doing, I actually spoke to their reception first, and then they directed me to the person that I needed to talk to so that we could get her set up with someone else. And it wasn't super stressful. If you're kind of like me, and sometimes it depends on the day, but sometimes I really can't handle what I consider confrontation. It may not be confrontational to the other person, but for me, sometimes it stresses me out to the max. And so I don't feel like I'm really in the position to speak to that person because I'm emotionally invested in my child. And if I see that they're struggling, sometimes it's hard for me to relay that in a way that's not combative, if that makes any sense, or isn't aggressive. Because, we get very emotional when it comes to our children. And sometimes it's hard to calm ourselves down to be able to have a good line of communication and a rational conversation with someone. So it was easier for me to speak to the front desk of the place where I take my children, and they were able to get me in touch with the person that I needed to talk to. And because I wasn't confronting the actual counselor, and maybe she was great, I don't know, but for my child, it just wasn't working. And so I didn't have to talk to her directly. So I didn't feel that trigger of emotion coming through. So I was able to get in touch with the people I needed to talk to take care of that situation. And they just took my daughter off the counselor's caseload and put her on somebody else's that actually now works for her. So don't be afraid to talk to somebody else if that confrontation stresses you out, because it's parents with children who have higher needs or, developmental disabilities and mental health disabilities. Our stressors are different. We can get triggered so easily because we're in the trenches all the time. So a lot of times our providers don't know what we have gone through to get to the point where we actually break. So it's important for us to be able to know that we don't have to have that confrontation if it's not something we think we can handle, and we can talk to somebody else at the same establishment and be able to get the help that we need.
I think from a provider's perspective, it's important to keep in mind that the need for communication, that yes, your children are our clients, but secondarily, the adults are our clients in a sense. Like if a child's doing good work, but a parent feels like this doesn't seem like anything's changing or happening, and we're not communicating as a provider with the parent, then they just make the assumption that it's not working instead of having communication. I mean, oftentimes when we're working with children, a lot of times we're using, non-communicative. We're not doing talk therapy. We're doing play therapy. We're doing other types of modalities with the kid. So it kind of looks like they're just having fun. And really, there's always a goal. We're always working toward a goal. But we have to make sure as providers that we are staying in communication with the parents who are like another client. Because you are the people that have to bring your child to the session. You are the people that have to see something changing or happening. So the communication is imperative.
Thank you. That's really good. Bevan, would you like to explain the Optum process if there's an issue with the provider, and then also include information about the Yes Concern and Complaint line?
Yeah, happy to. So Optum's job, or one of our jobs, is to provide a provider network for these services and to oversee and monitor the provider network. So we have all these providers contracted with us to provide certain services, and there are terms in the contract that talk about quality assurance. So anyone who feels that they're having a difficult time with the services they're receiving from a provider on the behavioral health side, that's an Optum provider, can feel free to contact Optum. And you can do that either on our website, which is optumidaho.com, or by calling our member line, which is 24/7, which is 855-202-0973. That number is also on the website. Typically, our response is to reach out. We gather the information from the parent and we reach out to the provider. I'll tell you, and I'm sure maybe Nate can attest to this as well. I have investigated a number of concerns and questions that parents have had where the manager of the agency or the owner of the agency wasn't aware of what was happening. And so I always encourage folks, don't be afraid of your provider. And I understand, again, from a parent's perspective, you don't want to become that nuisance parent. You don't want the agency to suddenly start treating your child differently. Or even if you're in a little bit of a negotiation with the school district over elements in the IEP. I've heard many parents about, I don't want the teachers to dislike my kids. I've rarely run into that as being an issue. And most of the time, most agency managers or owners want to hear from you. They really need to hear from you because they can't be everywhere where their workers are, where their staff are. And so don't be afraid of contacting them. But if it is something you feel like you need assistance with, that's where Optum's happy to step in. I've made a number of calls on situations like this. And we're happy to investigate those calls. Now, I personally have not been involved with situations where there's been calls to the Yes line about concerns. So Optum does not, the phrase we use is own the Yes program. That is a state. The state owns that program. The state has the data warehouse, if you will, on the CANS assessments. Optum did not determine the use of the CANS assessment. Again, that's something the state did. So that's not something we've had a lot of experience in. What I have seen is if families contact the state about concerns, if it's related to an Optum provider, the state again then engages Optum to help resolve those issues and complaints. I hope that helps. Please, someone else chime in if you have better information about the state's process.
That makes sense to me. So I do want to say something that I'm getting from all of you is how important communication is for parents and families to communicate with their providers, to communicate with each other even, because sometimes parent and child are not even on the same page. So that communication and keeping it open and not being afraid to talk about it is probably one of the number one things that I got from this. Thank you very much.
So Amy, I would just like to point out to Bevan's point about the concern and complaint line for yes, he is correct. If a concern or complaint that came in that needed to be Optum specific, they will route it that way. They will also route to Medicaid directly if it is them, children's mental health, any part of the system. And it doesn't have to just be a complaint. I know that parents didn't want to be complainers. So that's why it's also a concern line. If you see something that's happening with the system of care that doesn't make sense to you, or you don't think is happening quite the right way, and you're not sure who to talk to, you're not sure who owns that, you can go to yes.idaho.gov, and under the contact us section, there is information on the concern and complaint line. And then someone at the state can figure out who actually needs to address the situation. So the reason the concern and complaint line is nice is that it helps the state log issues to help resolve them system-wide. But it also, if you don't know who owns the thing that you're concerned about, they will help you get to the right place. So.
Very good information. So I'm looking at the time and it doesn't look like it looks like we're pretty much out of time. So I don't see any other questions in here. But I want to thank you all for participating. You all gave us so much good information to help our families with dually diagnosed kids navigate the systems of care. And if anything, it's great as a parent to hear providers and people with Medicaid and those departments of developmental disabilities and mental health and Optum. It's good to hear that you want to hear from us. It's good to hear that your desires are to work with us and that you do see and understand where we are coming from. So if anything, it's great to collaborate with you and to get your point of view as well as let you hear our point of view. So I want to thank you for participating.
Thank you.
Laura, are we?